I'm Dr. Satish Nallam, a general surgery and laparoscopic surgical practice in Clinic Nallam from Pondicherry. Today's topic is on Barrett's esophagus, a topic which is very relevant in today's GI practice, I would say. As you know that the gastroesophageal reflux disease in our population, the incidence is about 10% of the population. So it's very common practice to see patients suffering from reflux disease in our surgical and gastroenterology practice. The focus today is on Barrett's esophagus. The Barrett's esophagus is a condition where there's a change in the lining of the lower end of the esophagus from squamous to columnar epithelium. So this particular change happens only patients who are suffering from chronic acid reflux. So especially patients who have this problem for a very long time, and this as a risk for malignancy. So, cancer of the esophagus, which happens after a chronic acid exposure, which starts with the Barrett's and then converts into dysplastic changes and ends up in a adenocarcinoma. So it's quite a serious problem once it becomes cancer. And the presentation of patients with GERD and Barrett's esophagus is the same as like patients suffer from heartburn, acid reflux. The symptoms are the same in Barrett's esophagus and patients with GERD. So it's very important that a diagnosis of Barrett's is established. And these patients are usually in the older age group, more than 50 years old. Patients who are obese, patients who have lifestyle problems like smoking, alcohol, eating spicy food, heavy non-veg food, and eating late in the night. So these are all the associated risk factors of GERD. The same thing holds good for Barrett's also. The only thing, this exposure of a chronic exposure to acid reflux, definitely there is a chance of 0.5 to 0.1 to 0.5% of changing to Barrett's esophagus. So this particular condition, as we know that the diagnosis is purely on endoscopy. A good endoscopy will give us information about the changes in the lining of the epithelium, this columnar junction. And this patches can be a short segment Barrett's or it can be even a long segment Barrett's. So it's important that we do a biopsy. When you have a suspicion of Barrett's, it's always better to do a proper biopsy. And this biopsy will give more information on the changes we see. It can be just a dysplastic changes or it can be no changes at all. It can be mild dysplasia or high grade dysplasia. So based on the dysplastic changes or no dysplasia, we can alert the patient and also tell about the seriousness of this particular condition. So once we document it as Barrett's esophagus, it's very important that we have kind of a surveillance for this particular problem. So when there is a dysplasia which is low risk, it is always better to do a yearly follow-up with a endoscopy. And when there is a high-grade dysplasia, there are procedures like radiofrequency ablation, or we can do also excision of that particular segment by endoscopic mucosal resection. So when we think that the patient is suffering from Barrett's, it's important also to give them a very important message that patients should go in for lifestyle modification. It's probably the first thing we should do. Patients who have GERD, they should be advised lifestyle modification, like they're obese, they have to go for a weight loss, regular exercise. Patients should also change their timing when it comes to food habits. They should try to eating and sleeping should be at least 3 hours gap. The last meal in the day should be at least 3 hours before they go for sleep. And there's a head and elevation sleeping on the right side of the bed. So how best we can reduce reflux with lifestyle modification should be thought and should be done very seriously. And with these modification, lifestyle modification, then we can go for pharmacological means. The best drugs are always the proton pump inhibitors, which are available in the market. A proton pump inhibitor can be given based on the reflex symptoms that can be given once or twice a day, half an hour before a meal. So the proton pump inhibitors have changed the treatment strategies when it comes to GERD, and they have excellent results. But still, we do have patients with the refractory symptoms, and these patients sometimes they need more than PPI. Sometimes there is an addition of an alginate preparation, which can be given as a syrup thrice daily after food. So these alginates don't depend on your to be given before food, can be given after food. So this pharmacological management is extremely important when you see that the patients are having no dysplasia or low-grade dysplasia. When there is high-grade dysplasia, of course, this should be taken up very seriously. We have to do radiofrequency ablation on the lower end of the esophagus or the segment we're suspecting, and also can do sometimes a band excision of the that segment, particular segment, and send it for biopsy. So it's very important that Barrett's esophagus should be screened for all high-risk group of patients, especially elderly age group patients, patients who are obese and who are suffering from chronic reflux disease. This few words, I pass on the important message of surveillance for Barrett's esophagus, which is a definite risk for a adenocarcinoma of the esophagus. Thank you.